Shelley, would you like to do the roll call, please?
Mary Baker Shaw.
Ani?
Mike Dobbins.
Here.
Gil England.
Honey.
Keith Austin.
Here.
Harley Buzzard.
Here.
Joe Bird.
Honey.
Tom Crittenden. Hayden Duncan.
Honey.
Wanda Hatfield. Rex Jordan.
Here.
Steve Glad.
Honey.
Mike Shambaugh.
Here.
E.O. Smith.
Here.
Janice Taylor. Here. Victoria Vesco. David Walkenstick.
Honey.
Brian Warner.
Honey.
We have a quorum.
Thank you. Thank you. For approval of the minutes, has everyone had an opportunity to look over the minutes of our last meeting?
Move for their approval.
Second.
Move and they have been a second. All those in favor?
Aye.
Yeah. Opposed? All those in favor say aye.
Aye.
All those opposed, same sign. Okay. Before we start with our reports, I'd like to announce that Counselor Hatfield has called me this morning, and she has been detained in Washington, D.C. She is trying to find an alternative to get here today, and she is hoping to join us later today. And she asked me to announce that to Council. Our first report today is from Claremore, George Vallier. Good morning, George.
Good morning.
How are you today?
Good.
Yes, it is.
You have my report there. I'll touch on a couple of things. For the month of February, we took care of 134 patients in audiology, gave out 32 hearing aids. Dental had 827 visits. The diabetic group had 187 encounters. Our dietitians worked with 84 pre-diabetic patients. Lab had 1,689 contacts. The pharmacy filled 27,018 outpatient prescriptions, and we mailed out 8,072. Physical therapy had 184 contacts, and radiology had 2,271 contacts. So quite a busy month for February. Any questions?
Does anybody have any questions for George?
Oh, Counselor Buzzard, the Orthopedic Center.
Okay, I see the orthopedic center.
I went straight back and.
Is that the name of it?
That's it, the Orthopedic Center. I thought the same thing.
Straightforward.
I do have another question.
Yes, sir. Counselor Buzzard.
How is that, the office working or on the referrals? You said it's across the parking lot. Have you had any complaints about that?
I haven't heard any. In fact, I went over to check on them and see it since they've moved in, and I thought it was a nice place.
Yeah. Mm-hmm. What about the audiology? How many do you have up there? How many providers or experts? Or
We have one.
You have one?
One audiologist.
And you did 134 last month?
Yes.
Thank you.
Mm-hmm.
Thank you.
Yes, sir.
Yes, Counselor Austin.
Counselor Buzzard, I visited the Contract Health Office last week, and they were elated. The employees were, to have the space, be able to meet with the patients in true privacy and protect their confidentiality when they're meeting with patients, because they weren't really, it was a tough condition there for a while, and they were truly elated.
Yeah, good deal.
Any other questions? George, thank you for joining us today.
Thank you, guys.
And now, Dr. Jones, will you please join us? How are things going in jurisdiction?
Good afternoon. What'd you say? Excuse me, I didn't hear you.
I said, how are things going in jurisdiction?
Going well. We're busy every day, of course. Never a lack for work to be done. So you have the report in your packet, I believe, so I'm going to go over a couple of things. The Gears of Government Award there that is acknowledged on your report. I'm going to pull up my phone and read this because I had to ask myself what this was for. This is a new award. It's a national award. It recognizes individuals and teams across the federal workforce for dedication, support, exceptional delivery, and key outcomes for the American people. Agencies and executive councils recognize outstanding individuals and teams that exhibit the values and create success for any of the 3 outcome areas: customer service, accountability, and stewardship. So our physical therapy department at Three Rivers submitted a nomination, or they were submitted as a nomination, and they won that award, a national award, for their innovation and how they've integrated physical therapy into our primary care. So just wanted to recognize that and make you guys aware of it, that we were made aware that they just won that award too. So a nice little accolade for our health system.
How wonderful.
The second thing, it's not in your report, that I want to talk about a little bit is we had the director, Dr. Redfield from the CDC, come and visit. He requested a meeting with us and to talk about public health. So we had Miss Lisa Pivick, who is the director of our public health, do a presentation. And as a result of that, he sent back and wanted her to come and give that same presentation to his leadership, which she did in Atlanta last week. As a result from that, now she's been asked to come and sit to a Senate committee on Indian Affairs to give that presentation and sit as a panelist. So her work is with our public health system is being recognized nationally, and I want to give her the recognition for that. So she's doing a great job, and I know we have a subcommittee that's working now, and you guys get to see her and her team work on some of the things that we're doing internally. So just wanted to give her recognition for that. Okay. The other thing that I'm going to hit on a little bit, and I have another handout here that I'm going to pass out that I didn't have ready for this report. This just came out. So Councilor Lay had made a comment at the last committee meeting about we needed the Barry Switzer of recruitment to come and help us with our docs. So this little graph that I'm passing out right now is vacancy rates. This was just published by the United States Government Accountability Office, by IHS. In the first column, you'll see IHS vacancy rate. The second area is broken down to the Oklahoma City only IHS vacancy rate, and the third column is ours. So I'll read those off real quick. The physicians, nationally 29%, Oklahoma area 21%, within Cherokee Nation 10%. Nurses 32%, Oklahoma area 12%, Cherokee Nation 0%. Dentists 21%, Oklahoma area 19%, Cherokee Nation 0%. Overall vacancy rates for Cherokee Nation, IHS 25%, Oklahoma City area 11%. Our overall vacancy rate is 3.3%. So I wanted everybody to see that our recruitment department is doing a great job at getting our vacancies filled. And currently we're at 3.3%. Then the other things that we normally look at in our report is the referral approval rate. You can see is at 97.5%. We kind of fluctuate between 96.5% to 99%, and usually that fluctuation is those appeals and how those appeals go through, because the patients do have to, if they're denied, sometimes because it's not in our CHISD in the Claremore area, they have to get a denial from them before we can start working on it from our side. And so there is that little fluctuation of paperwork that has to be filled out in that interim, but we generally fluctuate between 96.5% to 99%. So we're at 97.1 for this report. And then you can see our third-party revenue looks good. We're ahead of what we were last year on the year-to-date. Our services are all up on our access to our health system. Almost routinely at every place we're up, seeing more patients than we saw the year before in the same month. And then you can see some of the other graphs, service delivered by quarter and things like that. If you have any questions, I'd be glad to answer them.
Yes, Councilor Buzzard.
And this is a comment, and I do have a question for you,
Okay.
Dr. Jones. The physical therapy room at the J Clinic, it's not big enough. You have a lot of people coming in for physical therapy, and it's just, they don't have the equipment to do what needs to be done. And what I've been told is that it was larger when the clinic was designed, but they actually took some of the space and put IT because the designer did not put a place for the IT department. I don't know what can be done about it. You know, the building's there, and I don't see any place to expand physical therapy, but we have a really excellent physical therapy person there. It's just not, it's not large enough.
Okay. I will check
I don't
into
know
that.
if it's anything we can do.
I don't know about the IT because I know that IT space was taken out of the dental side because there's a area there for IT
Well,
that
I
was
may
taken
have
out.
that
So
wrong.
I don't know what was changed, but I can check into it.
Okay, you may be right too, but I just know that the physical therapy part it's too small. The other thing, and I want to ask, I know I've been CC'd on the email about our dental scheduling. Why is it that we can't have people calling all day long? Is there a good reason that you do it at 4:30? Because if you do it at 4:30, you've got 500 people trying to make appointments, and it gets frustrating to our citizens. I know it does, and I don't know why you don't do it all day. So can you give us an answer to that?
So that question was asked last time, and in the response I gave you a written response to why we do it that way in the last written responses that I give to everybody. So if you have a specific question about
well, I missed the last committee meeting, so I didn't get it.
it went out to all the councils, so you should have a response from me in writing of why we do it that way. But I can tell you, I can give you a little synopsis
Okay,
of
yes,
it.
sir.
If we don't control, and to make it clear, we're talking about just patients that are getting into our system as a new patient, okay? Because if it's a
Sure.
walk-in patient, they're seen daily. If it's a patient that's already in our system, they're appointed at the chair side for their next appointment. You stay in that system as long as you make your appointments or as long as you call in and you change your appointment because something came up. But as long as you keep your appointments rolling, you stay in that system. And that can be 6-month appointments, you know, routine recall appointments, all that is considered in that. So what we're talking about call-in is those patients that want to get into our system for the first time, or patients that have dropped out because they no-showed their appointments. They didn't make their, whatever reason it is, they've dropped out of the system. So that's what those those appointments are for. So there's been a history, and again, we, you know, have gone through a whole lot of different programs to try to get to where we're at now. The no-show rate for our new patient exams, since we've been doing it this way, have gone from 48% down to about 16 to 17%. If you schedule them out more than 30 days, then either we can't get a hold of the people, because in today's times everybody has a cell phone. A lot of our patients have cell phones that they add minutes to, and when those minutes run out, they toss that one and they get another one. Phone numbers change. We can't get a hold of them. And then our provider is left with a block of time set up for new patients. We require every provider to do 4 new patients a day. So a block of time where they aren't productive because no one's filling that appointment. And it's too late to get another patient in because we didn't know they weren't coming.
Well, I guess I see your point, but if you had somebody answering the phone from 8 to 5 or whenever, then you would know all of this. You would know if it's an old patient, missed a patient, or want to make another appointment.
And we do.
At 4:30, you don't know who you're missing at 4:30.
We do have somebody answer the phone all day, but the issue is that we only have so many new patient exams to give every day, and we give them every day. At one time, we were trying to do it once a month. Well, then everybody forget, well, what day is it? You know, and you set this day, the second Tuesday of the month, or whatever day you set, and then that gets missed. And then we moved it to just the mornings. We tried to do it first thing in the morning. Well, that's when all your walk-ins on same days are showing up, so your people are tied up checking people in. At the end of the day, all the patients are checked in. There's no checking in anymore. So it frees up our staff to focus on answering that phone. Now, a lot of places only have 2 lines into the dental clinic. So if one line rolls over to the other line and both lines are busy, there's not another line to roll into. And the way our clinics are set up, there's not a place to put more people at the front. You know, some of our clinics, like Muskogee, have 4 people up front, so they have 4 lines it rolls into. But depending on the size of the clinic will determine how many lines we have in that clinic.
Well, I'm sure you're more familiar with the situation than I am and how things should work up there. But I guess I just can't see why we can't answer that person's question when they call in at 10 o'clock, you know?
If we, and they do, they say that we take call-ins at 4:30, and that's typically what we did. We surveyed our patients, and the patients decided that, you know, from the people we surveyed, they'd rather have it at the end of the day than the beginning of the day. It was easier on our staff to do it at the end of the day. But if you just leave it wide open all the time, you got to, where are you going to put those patients? And if you start stacking them up further and further out, you'll have the same situation we have in optometry, where patients are stacked up 11 and 12 months, and then they don't show up for their appointment, because I'm not going to remember appointment, you know, 10 months from now. And I feel like I have a pretty good schedule, but I'm still not going to remember that.
I see that. It just, you know, we're here to serve the Cherokee people and Cherokee citizens, and you've got people sliding that phone line at 4:30 and they can't get through. And we hear about it. I hear about it a lot, and they're just frustrated. I don't know. Maybe it's...
But I will tell you that in some clinics, we don't even give all the appointments away. So, for example, if we have appointments left from yesterday, we fill those first, because they're given 30 days out. So if they didn't fill all their appointments for new patient exams yesterday, they'll fill those first and then give away the ones for today. But every clinic has 4 new exams per provider that will be scheduled that day. So some days it's less, because if the provider takes off, you know, is on vacation, then obviously we can't schedule those new patients, because there's not going to be someone there to see them. So that's the way to maintain it, so that we have the most efficiency we can have with our providers also.
And I don't know if the other council members get these calls, but I do, just frustrated people. But the other question is do we have 2 providers for the dental service at Jay? I haven't been in there.
Yeah. We have 2 dentists and 2 hygienists.
Oh, okay. And then the other thing is on the clinical director. Where are we on that? Are we going to get a permanent one? Or
That's a, yeah,
where
that's
are we?
a,
I mean, it's been going on now for a month.
I agree. And that's a employment, you know, employee issue that
Yeah.
I can't comment on, but, you know, that's in HR and has to do with all that. So I can't comment on any of that, the details of that. But we are aware, and Ms. Cochran, who is the ambulatory senior director, she is spending part of her time, and Jay, every week, making sure things are continuing to run correctly. So.
All right, well, I think we about beat you to death on this scheduling stuff. So, but physical therapy, if you check on that,
I will.
appreciate it.
I wrote it down.
It's not large enough
Okay.
to accommodate our people.
Yeah.
Thank you, Madam Chair.
Counselor Lay.
Thank you, Madam Chair. Doc, and remind me, I think when people come in with a real emergency or tremendous toothache, you try to see them wherever they're at, I think.
We will see them.
Yeah.
We don't turn anybody away. Anybody that comes in as a walk-in is seen the same day. I don't care if we have to stay till 7 o'clock at night. We don't turn people away. When I first came and took this job, they were limiting it to, per clinic was limiting it, you know, at Hastings, 10 people. So if you were number 11 signed up, tough, go home and we'll see you tomorrow, get here earlier. We don't do that anymore. We see them until they're gone. And that's for, they can show up at 4:59 and our clinic closes at 5. If they show up and a person shows up and they've got a problem, we're going to address it if we have to stay late.
And I don't know that a lot of our patients know that. I've taken advantage of that once, by the way, so thank you. And the locum tenens, are they included in this 10%?
No, because a locum tenens is someone who's just filling in temporarily.
Well, some of them were there a long time. I don't know how temporary a locum tenens is.
And some of it has to do with what specifically the field that they're covering. You know, for example, and I'm not just throwing this out there. ENT, ear, nose, and throat. Those people are hard to find. You know, we have to contract with someone to provide those services for us because they're not even the best hospitals have trouble. You know, the number one hospitals in the nation have trouble finding those people. There's just a reduced rate of those, you know, of those specialties out there. We met with a cardiology unit provider this week, and they were telling us the number of cardiologists that are going into cardiovascular surgery is falling off at such a rapid rate that, you know, we've got to start making some plans now for 10 to 15 years from now. We will be in a lot of, there'll be an emergency, I guess, if you want to say it that way, across the nation, because that specialty is falling off so rapidly. People are not going into that specialty anymore. So you'll have these groups that form that they specifically do that, and you won't have a choice. If you want that service, you're going to have to contract with these groups.
And that kind of leads into some of the other, I mean, and I didn't know Jay was short of a medical director unless.
Not a medical director, a clinic director.
Clinic director.
Yeah.
Are we still short at Nowata and Ursula on medical? I know you're looking at someone, but we haven't. Have you pulled the trigger on anybody?
I'm not sure the contracts have been signed yet. I know that we've offered a contract, but I'm not sure if that contract's been signed yet, so I can't comment on it until I know for sure the contract's been signed.
Do we know how long that's been? Those have been open?
I don't know how long they've been open. I know we've been covering Oshaleta with Dr. Gray, and we've been covering Nowata with Dr. Baker up till now. And
Would
so
you like to know how long they've been open?
the position itself, is it sure?
No,
Yeah.
I'll let that.
Yeah.
It's been a while,
Yeah.
a long while. And so we're getting ready to have a lot of needs at the new clinic.
Mm-hmm.
And so when I mention some kind of super recruiter, all of this entails what I was discussing and talking about. We've got a great crew now, but we're still short at our clinics. And I don't know the percentage, because I don't know how that's figured in with locum tenens. And so I know that we've been short medical directors at Oshaleta and Nowata over a year. And so this, and when we borrow someone, and there've been good ones, by the way, I've been told these folks are good and they're appreciated. But then it takes away from where they come from, and then it takes away from where they're going. And so all of a sudden, I've got a lot of empty slots that is not really reflected in what you're giving me here.
Yeah, and to my knowledge, Oshaleta is full, and so is Nowata. I know that
Just recently.
Yeah, we got word that for the that they were completely full of providers, and Oshaleta was full of providers. As a matter of fact, the providers we have at Oshaleta are in some ways, in some categories, leading the pack.
They are leading the pack.
So they've been very, very good, and we really appreciate them.
And I think there's been another slot provided, but it's being looked at about being filled.
Right.
And so my point was this, is that even though in areas we're good and some areas we're not, if you don't have leadership, we've got a lot of good people that lead themselves, quite frankly, and that's what they've been doing for a long time. They've been doing a good job at it.
Right.
And we feel a little bit left out where I'm at.
All I can say is what's happened prior to me sitting in this seat is I don't have any control over. I'm trying to move forward with, the things that I see administrator's responsibility, which in my philosophy on administration is we need to get things out of the way to allow the providers to do what they do, which is see patients, and take away the things that are hindering them from seeing patients. So that's the things that I work on. That's the philosophy that I'm trying to impart into our leadership currently. And I think that's been seen by some of the providers and some of the decisions we've made. And I think you're starting to see the morale coming back around, and they see that, that we value their services, we value what they do every day. They didn't go into healthcare because they didn't want to see patients. They went into healthcare because they wanted to see patients. So our job is to get those obstacles out of the way and let them do what they want, what they went into this, into that field to do.
I appreciate that. It's just been a lot of long-term obstacles, one after another. Sometimes I look at your org chart. It seems, unless something happened recently, it's been that way for a long time. And our services have been boosted up quite a bit. I wonder, you know, and I'm not in your field, so I don't know. But the org chart maybe needs to be looked at.
We're currently working on it. That's one of the, I have a list of 4 or 5 things that I want to accomplish. The org chart was number 3 on that list, mainly because we have to have an organizational structure before we open up the new joint venture building. Our current organizational structure is not inclusive enough to take on all the things that we're going to have to do when we go into that. So we're looking at an overall restructuring of how we organize our communication up and down.
And that's, I've asked before, but are you going to have to split it out? Split the organizational chart for the new clinic and/or Hastings Hospital together, and have the outer clinics separate? Or?
So we're looking at some, you know, I'm getting some input from people who do that, you know, that are experts in organizational structure. But you've got to remember that the new building is an outpatient facility. It's not a hospital. Hastings is a hospital, so we're going to be separating inpatient and outpatient because it's 2 different with a lot of different rules. Hospital is 24/7. The outpatient facility is not 24/7. It'll have a surgery center and things like that in it, that we do a lot of things that were normally done in the hospital, but it is an outpatient facility. So it has to be ran like an outpatient facility, not like a hospital. There are different regulations on those.
I guess that's my question. Will that be split off?
Yeah. I mean, it's still going to be on campus. It's still going to be we still have docs that go back and forth that will utilize in-service and they'll utilize outpatient. And we still have to have all those things in place to allow that communication, those services to be carried into the hospital. OB is a very big example of that. You still see patients in an outpatient setting, but you have the child delivered in an inpatient setting. So we have to have all those things in place. Complicated, yeah.
Thank you.
Yes, Councilor Walkingstick.
Why doesn't Will Rogers have a generator at the hospital?
That I cannot answer. That's before me, and that's the facilities issue. I do know that we have looked at using or putting a generator up there, but I don't know. I can't answer that directly because I don't control facilities.
Are you aware of the complications that take place when electricity goes out up there?
All I can say is facilities currently is not under me. That I don't control facilities. That's under the buildings, and all the maintenance of the buildings are currently under facilities management, which is under a different department than me.
Well, the quality of care falls under you.
Quality of care does fall under me.
So, are you aware of what happens when electricity goes out at Will Rogers?
I'm aware that when electricity goes off, if we can't provide the services, yes.
Okay, because there were doctors with their iPhones, lights on, seeing patients while electricity was off. Also, the blood that they had to take it up to the fire station to use their generator to keep it at a certain temperature.
Yeah. Again, that falls under
my
facilities, does not fall under me, so I have no control of it.
How long has it been like this?
That I can't answer. I've only been in this job since December, so I can't answer that
Do you
question.
guys have a plan to correct that?
That would be a question for facilities.
Huh. Okay. Thank you, Chair.
Excuse me for injecting here. Councilor Walkingstick, how often does this happen, or are you aware? I mean, this is the first I've heard.
A couple of weeks ago, and they've had it happen twice in the last month. And they said the doctors had iPhones seeing patients with their flashlights, and that the blood that they take or they store, they had to go up to the fire station up the road to store because they had a generator up there, and that's a procedure they have to do every time the electricity goes off at Will Rogers.
Question. Are we responsible for that blood once it leaves our premises? That's alarming to me as a healthcare person here.
I'm not aware of that situation, but I will check into it and find out. what's going on.
We should be alarmed
I
here.
leave it up to, you know, that if that situation's going on, that would fall on the clinic administrator there to let us know that that's going on. Obviously, I'm not in Nowata, and unless I have communication back from them to let us know what's going on, I can't know that. So, to my knowledge, I have not been made aware of that situation since I've been here since December.
My question, so how many of our clinics don't have generators?
That I don't know. That would be a question for facilities.
Yes, Counselor Taylor.
Not long after I came on board, it was called to my attention that the clinic at Salina did not have a generator. And when I brought it up to health at the time, they were not aware of that.
Okay.
They quickly got in line, and we have a generator up there we've had for several times.
How much does it cost?
I don't know, David.
I'm just
But
curious.
I'm
what's
just
possible.
saying, they don't know there's a problem until they know there's a problem.
Counselor Lay.
And to follow up on that, how old was that clinic, 10, 12 years old, you? That has never had a generator, and they've always had that problem in Nowata, electricity going out. Sometimes it's not long enough to do what was stated here. Health knows about it. Health has known about it ever since the clinic's been built. Nothing's ever been done about it. And so when a counselor comes to you and says something about that, either in this committee or to the side, we'll look into it. I'll get back to you. And this is, when you have a leadership vacuum, we got one, because we don't have the whole org chart filled out for those two clinics. Then you run into these situations, and this is kind of what's frustrating to me. And this was brought out, and it's been brought out before. And so I'm certain the clinic administrator has sent that up the line. And at the line, things get stopped. And that's frustrating to me. That's why that org chart needs to be looked at, because when you got a stoppage, when you got a stranglehold up that org chart, and I can tell you where it's at if you want to see me after this meeting. But anyways, that happens consistently. And we don't want any bad news going to Tahlequah. You ever heard that one?
I haven't heard that, but I will
Well,
tell
I've heard it
you,
a lot of, ever since I've been here,
well,
and before that.
with all due respect, I will tell you that since I've been sitting here, if you've had an issue, I've tried to address those issues and get you feedback. So I can't help what's happened before I sit in this chair. But I can tell you since the time I've sat in this chair, if you've made me aware of an issue, I've either got your response back or I've taken care of the situation and let you know it's taken care of. So that's all I can tell you I can do, and I will continue to do that in this capacity.
And I appreciate that, but I want you to know people before you have known this. This administration has known it. And we keep flying by the seat of our pants, seemingly. And so if we're going to do health care, let's just do it right. And that takes into consideration the leadership. And that takes into consideration that org chart. And I've brought the org chart up before. And so there's a stranglehold somewhere between the outer clinics and Tahlequah. Don't let the bad news go up the ladder.
Like I said, I'm not aware of that, and there's nothing I can do about what's happened prior to this, but I can tell you that I will look into it and find out what we need to do. Again, facilities doesn't fall under health currently. So,
And so who's in charge of facilities? Why isn't that person sitting in the hot seat, I guess, instead of you? And I apologize for you to be sitting there.
facilities currently falls under, was under Bruce Davis, and now it's under David Moore, I believe.
Yes.
He's coming up.
Yes,
And
thank
David
you.
Moore probably just took that job, I'm guessing.
Okay, Speaker Byrd. Yes.
Just a moment here. I've still got the floor unless you're taking it away from me.
Okay, go ahead. Finish your
Thank you.
thought here.
And so this is the frustration that you see with folks in the outer clinics, and why we ask these questions continuously, and why sometimes, I'm looking for leadership. And I've been a year and a half without it on the medical side of my two clinics. And so doesn't anybody get that? Did it ever hit home? That's all I got. Thank you.
Speaker Burke.
Yes, we've had some interim people filling in some of these positions, and Dr. Jones, we appreciate your prompt response when we have an issue. Yeah, the facilities guy is going to report here. I see him just walk through the door there. But what we need to do as council members is that we all should be in communication with whatever takes place in our facilities, whether it's housing, health, and so forth. And the only thing I would encourage is the executive directors, please communicate with your chair of the committees. Because if you do that, if you'll communicate with the chair of the health committee and you communicate what our issues are, and that goes for committee members and council members, then we can all stay in communication. With the growth that we have at Cherokee Nation, I remember when I first got on the council, we only had like 50,000 members. We're up to 300 and probably knocking at 70. These issues are not going to get much better because we're seeing so many patients, so many people needing health care. But if we communicate with each other, at least address these issues and stay with this transformation we're going through, we can resolve a lot of these issues. But that's what these chairs are for, the chairs of committee. She needs to be in the know. If you're in the know, she needs to be in the know. Because a lot of times the chair of a committee can bail you out on a lot of these issues. She can take care of a lot of stuff before it ever gets to you. Because Dr. Jones, you don't need to hear all of this. You're taking care of the whole spectrum of the health committee. You have people under you. You delegate that to and say, I don't want to hear about a patient didn't get seen yesterday. Pass that on to Dr. Montgomery or Dr. Nolan or somebody else. You've got other issues we want you to be taken care of. Does that make sense?
Absolutely.
And again, executive directors, I need to meet with the chief of staff and the chief and say, you guys aren't doing a very good job of communicating with the committees here. The chair of each committee, we should be in the know on these. That's why you have chairs of committees. So that's all I'm going to say. And on this facilities, on the generators, once we get with the facility guy out there, let's do an assessment and see how many of these clinics need these, and let's do a study, feasibility study, and let's, if we need to purchase those, do it before the budget time comes, because I don't want to hear about generators in December. Okay?
I agree.
Make sense? Thank you, Madam Chair.
Yes, makes great sense. Thank you.
I have one other thing I want to report to you. I want to have Dr. Montgomery come up and give a little report about an issue that we're dealing with, and we just learned about it, but I want to make you guys aware of it and our
Absolutely.
patients too through this venue. So,
Absolutely. Good afternoon, Dr. Montgomery.
Good afternoon. I think in the spirit of communication, I wanted you to be aware of an issue, and I want to start by saying the vast majority of our patients that have lab tests have their lab tests done internally at the hospital or in the clinics. Due to the complexity of some lab tests, we have to send blood samples out to outside labs, and the primary lab that we use for outside tests is called LabCorp. Again, this is the lab we utilize to perform testing outside of our system. I received a list of names today of patients who had a blood test done by LabCorp using a faulty reagent, so the results were inaccurate. These tests were performed over a 6-month period beginning last September until February, and they just notified me about this. The test is a test called thyroglobulin antibody. It's a very unusual test, and it's a test that's not used in isolation. It's usually a test used along with several other tests to help diagnose and treat patients with thyroid disease. I've discussed this with the LabCorp representative. I've discussed this with a thyroid specialist that we utilize in Cherokee Nation Health Services, and I've discussed this with multiple providers within our health system. And based on our discussions, the risk assessment to our patients is deemed to be very low, very low. Again, this is a test that's not done in isolation. It helps clinicians make a diagnosis or make decisions regarding treatment, but doesn't typically have an immediate or urgent consequence. And based on this low risk assessment, I'm recommending that patients be notified by mail to have testing redone at their convenience, not emergently, at their convenience, which means at their next appointment. If they don't have an upcoming appointment, I'm recommending that they contact their provider to set up an appointment to come in and have the testing done. So again, I wanted you to be aware of this. We'll be sending the letters out later today and first thing tomorrow. You may get some calls. If you have questions about it, please contact me. But again, we're urging patients to contact their provider about the test. Do you have any questions for me?
Counselor Shambaugh?
Yes, sir. Ballpark, how many patients are we talking?
306.
What is the risk to the 306 patients, Dr. Montgomery?
Well, again, I consider it very low risk. There's no immediate consequence. It's a test used to help the clinician typically diagnose various thyroid diseases. I'll throw a funny name out there. Hashimoto's thyroiditis, or autoimmune thyroiditis, is the commonest cause of an underactive thyroid gland. And this test is used to help them make that diagnosis. But the other tests that the clinician typically orders guide their decision about whether to offer that patient thyroid hormone or some other treatment. Does that make sense? Good.
If I could add one thing, I think I could probably speak for all of us that we appreciate you identifying that we have a problem, identifying the patients that need to be contacted, and doing that in a timely manner like you're doing. That's important, and we appreciate you for that.
Absolutely.
Thank you. And again, I would urge you, if you're contacted by your patients, just to reassure them, get the testing done at their convenience. Thank you.
Which clinics would?
This is system-wide. This would include patients tested that have their blood drawn at Hastings and the outlying clinics. So it's a relatively small number over a long period of time, 6-month period of time, for all the numbers of patients that were tested. And by the way, this isn't just Cherokee Nation patients. This is testing for patients all over.
Thank you for sharing that with us. We appreciate that.
Thank you.
Anybody have any other questions?
Good report. Just for Dr. Jones, I'm sorry, could I have 2 minutes after we're done?
Okay, I have some questions now. I just recently heard we may be interested in having a PA or a registered nurse program. Is that true? Do you know anything about that at this time?
Northeastern State University has started a PA program, and they've asked us to, take on do some of their help with their clinicals and things of that nature.
How will that coincide with Oklahoma State University, and are we going to have the facilities available to encompass that?
Well, we're going to work partly with Northeastern Health Systems to provide those type of, same thing we do with our residency program now. So we don't see a problem with it. We think it's going to work out because it's a different thing. OSU is medical students. These are physician's assistants, PA students. So they'll be working with a different subset of providers.
Okay, and Oklahoma State University is on board with this, is that correct?
Yeah, theirs is a totally different deal. It's medical, and we're looking at, and the thing with them, and I hope people understand, is once they go through the medical school, then they come into a residency program. OSU does not necessarily own the residency program, and we are looking at picking up the residency program. So currently that's a shared service between Northeastern Health Systems and ourselves. Northeastern Health Systems actually owns the residency program. We are looking at different opportunities to bring those people onto, or that residency program onto us.
Okay. Tell me, do we have a physical therapy program at
Yes.
Hastings?
Yes.
And is it working at this time?
Yes.
Okay. Recently, one of the counselors referred to scheduling dental appointments as Publishers Clearinghouse. You have one Publishers Clearinghouse. Is there anything you can do to schedule our appointments more professionally than a 30-minute window occasionally? Can you ask the facility there if they can put their heads together perhaps and come up with an alternative plan that perhaps is more professional and will help our Cherokee citizens better? Can you ask them if they can come up with a better plan than what we're currently using?
I'd be glad to sit down with you, because I was the dental director that came up with tried different pilot programs. I'd be glad to sit down with you, show you where we've been and where we're at and why we are doing it the way we did it, kind of like what I explained there and what I wrote in your last remarks from the last meeting. I'd be glad to sit down and talk to you about it. And we have tried a multitude of different options. This current option has got our no-show rate down to about 16.5%, which is fantastic, considering that we're scheduling out 30 days. So as far as professionalism, they have a script and how they handle that. I don't know that they're doing it, every single one's doing exactly as scripted, but those lines or those appointments are available until they're all given away each day. Each day there's a number of appointments at each clinic for that specific clinic. So, but I'd be glad to sit down with you and talk to you, and I'd be glad to have you attend a leadership meeting with all the dental directors, and you can discuss it with them, and they can give you some feedback of what's been tried and hasn't been tried.
I'm not the counselor yelling about this, but I would be happy to show up, and let's invite the counselors. As a matter of fact, let's invite the entire council and see if anybody that wants to can show up and see, get filled in on it, okay?
I'm just going off what speaker said, that we communicate with you and you communicate that out. So I don't know the appropriateness of having more than 1 or 2 counselors at a time in that meeting.
You there.
I'd be happy to come.
Okay.
Thank you.
Then we'll set that up for you and have you attend, and you can ask those questions and they can give you feedback.
Thank you. I appreciate that very much. Thank you. I also want to ask you a question. I want to talk to you about our patient records and their security. Does any employee have access to our patient records? If I'm a nurse at Hastings, can I have access to anybody's records at Hastings?
If you have the ability to sign into the electronic health record, you have access according to your role. When you access a patient's record, there is a log kept of every single person that enters that record. You have to have medical necessity to enter that record, or you're violating the HIPAA laws.
Okay, I'm glad to hear that. Now, if I work at Mankiller Clinics, let's say, can I access a record at Hastings?
Absolutely, if you have medical necessity to do so.
Okay, what if I really don't, but I want to? Can I still have that access?
If you do that and you're in violation of the HIPAA, then we will take disciplinary action just exactly like that we're supposed to, and that'll be turned over to HR, turned over to the AG's office to determine the extent and what violations have been done.
Okay, but that's only if I'm caught, is that correct, or will I be flagged?
That's just like that. I mean, we can't determine your medical necessity. If you're a doctor, or a nurse, or a PA, and you're getting into someone's chart to look at their history because they're being seen by you in that clinic that day, that's medical necessity. So medical necessity is determined by, the reasoning for being into that chart. But do you have ability to just go in and look at the chart? Absolutely. I mean, you could do that, and if you do violate that law, then you will be disciplined accordingly.
My question is there someone that monitors this medical necessity?
Our IT department we can call for an audit on any chart at any time. But
that's
typically those are done.
That is the only oversight available.
Those are typically done when we have reason to believe that someone's chart has been entered incorrectly.
Okay. Someone recently drew my attention to something, and it involved a divorce among someone, and someone was employed, and I have reason to believe it was a crime.
So if you believe that and you get that to us, we will check into it. And like I said, you cannot enter into a chart without having a documentation of entering it, and that all runs on the back end of the electronic health record. You don't see that, but we see exactly the minute you log into a record and the minute you log out of a record. Okay. All that is recorded.
Okay, so it is possible. I'm glad to know that. Okay, thank you so much, Dr. Jones. Yes, yes, Councilor Shambaugh.
Just so this gave me some information. No Water is the only clinic that doesn't have a generator, so I had facilities check into that. So to answer your question, so I got it back to you quickly.
I just had something I wanted to share with you, and I really don't need a comment, but I had a lady approach me in Jay a couple weeks ago, and this goes back to the stem cell stuff that we discussed. She was a candidate for knee replacement and they suggest she was going to get a knee replacement. She went and tried this stem cell therapy in Arkansas. Her cartilage was at either 0.3 or a 3, I don't know, whatever it is. But so she had this procedure done on her knee. She couldn't hardly walk on it. She says now, if she wanted to, she could run up the stairs. Her cartilage just went to a 7. So that was kind of unbelievable to me to hear that from her. And she's a school teacher. It's a true story. So, and maybe she's not the norm, but Boy, that shows some great promise for a lot of things, and they're doing it in a lot of different states now, and Arkansas is really into it right now. So I do hope that's something that we look into, and if that's something we could implement maybe toward our diabetic people, and if it could help with losing some limbs or regenerating tissue, that would be a wonderful thing. But it certainly helped her in her life. She said, like I said, she was going to get knee replacement, and now said she can run up the stairs if she wants to. So I just wanted to share that.
Yeah, well, I appreciate it, and I will say that we try to keep our scope of care of what we do in an evidence-based environment, so that we stay, because obviously we can't do everything for everybody, but as that research and as that stuff moves forward, of course, it becomes more mainstream and more there's a lot more evidence-based behind it. But it's pretty much, it's in the preliminary stages of that. You hear success stories and you hear failure stories a lot, and we want to make sure when we start offering something, and I'm not that particular thing, but anything that we add to our scope of care, we have some evidence-based reasoning for why we're doing it and what our success and failure rate's going to be, and are we willing to mitigate those losses against the successes. So yeah, I mean, our medical team stays ahead of those type of things out there all the time.
Yes, Councilor Watkins.
We had a constituent in our district that she is heart's beating at a low percent. She's needing a defibrillator, and she's needing a life vest to take care of her just in case her heart was to stop. This life vest would keep her going until she was able to go to a hospital. I believe it cost us around $3,500. My understanding is that we're not supplying these life vests anymore under contract health. I guess my question is these life vests, is there a way that we could buy a bunch of them and reuse them for different patients, or is it kind of a one and done on these life vests? Could you answer that, or is that a Mr. Carey question? Or?
Probably a Mr. Carey question on the contract health side of it, and maybe a Dr. Montgomery question on the reusable of the life vests, because they are exterior defibrillator is what they are.
Okay.
Yeah.
As Dr. Montgomery, can those be reused? I mean, if we were to buy a bunch of them, could we
don't need one.
not rent them out, but
Refurbish?
Yeah. Yes.
Refurbish them?
Yeah, refurbish them.
As far as a coverage issue, I will let Steve address that.
Okay.
They are reused, yes.
Okay, that was my question. So I guess the next question is, Mr. Carey, is there a way that we could purchase 20 or 30 of them? And
So don't answer that. Just say, I think, Councilor Walkingstick, the use of cardio defibrillator vests it's not a black and white clinical situation when every patient that has a heart condition needs one. There are a whole host of different diagnoses, very specific diagnoses that may or may not benefit from a cardioverter defibrillator vest.
Okay.
So to say that we would buy a large number of them, it's a treatment that's offered to a small select number of patients. So purchasing a large number of them would probably not be as cost effective as getting them from someone else and paying for it through contract health dollars. I hope that makes sense.
Yes.
If we had, large utilization, something, yes, that makes sense to purchase them. But if it's a small number of items in rare circumstances, you typically want to just get that through a DME company.
Well, the patients that are identified as being in this small population of people, and is there a way that we could assist them?
Well, again, if a patient, if a provider requests that treatment be offered to that patient, if it's approved or not approved by contract health, if it's not approved, you can always appeal that decision and then see if there's more additional information that would help our medical review committee decide if that patient was appropriate for treatment with a defibrillator vest. I hope that answers your question.
Yeah, this contract health is, nothing against you, Mr. Carey, but it's very frustrating when someone has an illness and they're sick and they're being denied by contract health and they don't have any any type of coverage, and if they're using IHS coverage, so, but they get denied and they're ill and there's no way out. Like they're relying solely on Cherokee Nation to get them off of give them a life vest or hip replacement or whatever it is. So I guess with this situation, I thought a solution might be if we purchase a few of these life vests and reuse them on different folks, because I think she said the cost was $3,500.
So if you will get with me afterwards and give me the specific situation you're talking about, we'll be glad to look into it. And it may be the denial, like Dr. Montgomery said, may be incorrect. Some paperwork is not filled out correctly. But if you look at our approval rate, we fall between 96.5% and 99% on contract health on all services. So it's, those ones that fall outside that are very, very unique outliers. And that's why that appeals process is there, so we can see, because they have an algorithm they go through, and these things have to be done in a certain way, and then once they fall outside of that, that's why that appeals process is brought before a committee that looks at each one individually, and that's where you get that 96 up to 99% approval rate.
I was told that we're not doing Life Fest anymore.
That's not true. I think, again, it depends on the clinical diagnosis and indication. It's not across-the-board denial, Counselor Walkingston.
Okay. So, all right, well, I'll get you the information to try to get this taken care of.
Because there are things that are appropriate for certain types of diagnosis. We don't have the ability just to, because the physician says, I think that's what you should do, well, we need to know why you think that's what you should do. Because we don't have the ability to just write it, have an open checkbook for every single thing just because someone that sits on the outside of our system thinks that's what you need. We need to know why you think you need that. And if if it's appropriate, then of course our committee is going to approve it. But it's not just I want it, write me a check and pay for it.
Okay, that's all I have. Thank you, Chair.
Okay. Yeah, we need to wrap this up. Let's go on to old business. Any old business? Any new business? Councilor Warner.
Yes, ma'am. Thank you, Madam Chair. I'd like to make a motion to amend the agenda to include a resolution authorizing legal aid services of Oklahoma to reapply for AMCOR's funding on behalf of Cherokee Nation to continue the medical legal partnership with Cherokee Nation. I put that in form of a motion.
Motion's been made and second. All those in favor, say aye.
Aye.
Any opposed? Same thing.
Yeah.
Yes.
All right. Now I'd like to move that we approve a resolution authorizing legal aid services of Oklahoma to reapply for AmeriCorps funding on behalf of Cherokee Nation to continue the medical legal partnership with Cherokee Nation. I put that in form of a motion.
Second.
All those opposed? Excuse me, all those in favor say aye.
And I need it to go to full council tonight.
Okay, motion's been made and second, made. Motion's been made. All those in favor say aye.
Aye.
All those opposed, same sign. Mike, did you have anything you want to discuss?
Announcement.
Yes, announcement.
Just to inform the health committee, complete health committee, the public health subcommittee has been meeting, and part of what we've been doing is looking at ways to improve health club / exercise club access for Cherokee citizens outside of Tahlequah. Each of our individual counselors as a part of that work group has different ideas, but I feel like we're making a lot of progress. We're hoping maybe in 30 days we'll have things kind of finalized and crystallized, but I'm open to further input, and I'd certainly welcome it. So just want to let the health committee know that that's going on a little bit behind the scenes. We're trying to just enable our Cherokee citizens outside of Tahlequah having an exercise option. We're for the most part, partnering with private facilities.
Wonderful,
Thank you,
Mike.
Madam Chair.
We sure are proud of the work your committee's doing, and thank you for that very much. We appreciate all of your all's involvement in that. Motion to adjourn the committee.
So moved.
Second.
All those in favor?
Aye.
Aye.
Motion carried.